Okay, so next we'll go to examination of eighth nerve, eighth nerve discussion, that is a vestibulocochlear nerve. Again, like all the other cranial nerves, here also important is anatomy. You should know the anatomy of the eighth nerve, then only we can think properly and examine properly. Okay, so first I'll tell the labyrinthine membrane. So here you can see ampulla, utricle and saccule, and here there are semicircular canals, superior, lateral and posterior. These semicircular canals will deal with the rotation, angular movements, whereas this utricle and saccule deal with the linear movements. Okay, linear movements. And this is the cochlea, and this is the cochlea. Now I'll just discuss the acoustic nerve and its connection. So here what happens? See, from the semicircular canal, vestibule and the utricle and saccule, the nerve fibers will join together to form vestibular nerve here, and the cochlea, from the cochlea the nerve fibers will go in a cochlear nerve. Okay, from utricle and saccule and from semicircular canals you have vestibular nerve, and here from the cochlea you have a cochlear nerve. So both join together to form the acoustic nerve, and the cochlear nerve will synapse in a dorsal cochlear nerve and ventral cochlear nerve, and the vestibular nerve will go and synapse in the vestibular nuclei. So the cochlear pathway, here it is shown from the organ of Corti, scala vestibuli, scala media and scala tympani. The ganglia will go there, and then it synapse in the ventral and dorsal cochlear nucleus. Okay, and then it decussates to the opposite side. Most of the fibers will decussate to the opposite side and synapse in the olivary nucleus. This is the olivary nucleus, this and this. Synapse in the olivary nucleus, superior olivary nucleus, and then it ascends as the lateral lemniscus. So I had shown last time, medial lemniscus is nothing but nucleus gracilis and cuneatus. Lateral lemniscus are the fibers carrying the cochlear fibers. So they go upwards and synapse in the inferior colliculus, and then they project to the temporal lobe. So I repeat, the ganglia, spiral ganglia in the cochlear, scala vestibuli, scala media, scala tympani, these ganglia will go and synapse in the ventral and dorsal cochlear nuclei in the brain stem. Then they decussate and synapse in the superior olivary nucleus. From there they ascend as a lateral lemniscus and they synapse in the inferior colliculus, and from there they go to the temporal lobe. Okay, this is about the cochlear pathway. Now let us examine how to do Rinne's and Weber's test. Okay, so we have examined Rinne's and Weber's test. Okay, so you know now how to interpret Rinne's, Weber's and absolute bone conduction test. Okay, now what are the cause of, what is tinnitus? Tinnitus is a ringing sensation in the ear. What are the cause of tinnitus? So tinnitus is nothing but a audible bruit, sometimes it is called as audible bruit, sometimes is nothing but a tinnitus. A pulsatile tinnitus is nothing but a audible bruit. You can get in a AV malformation, keratoconus fistula, carotid stenosis, hypertension, glomus tumor, you may get a tinnitus. Other common cause of tinnitus is Meniere's disease, drugs, CP angle tumors. Okay, toxic drugs which are toxic to the vestibular apparatus. So what we did, the test, Rinne's and Weber's test, this is the interpretation. If there is a conductive hearing loss, bone conduction is better than AC. Normally ear conduction is better than bone conduction, that is Rinne's positive. But in the conductive hearing loss, bone conduction is more than ear conduction. Okay, and Weber's will be in a conductive deafness will be lateralized to the abnormal side. In a sensory neural deafness, AC is better than BC. Okay, that is Rinne's is positive only in sensory neural deafness, but Weber's will lateralize to the normal ear. That which I already showed you how to examine the Rinne's and Weber's test. Now coming to the vestibular pathway. So vestibular pathways. So here the vestibular nerve, the ganglia scarpa will go on synapse. There are 4 vestibular nuclei. You can see here medial, inferior, lateral, and superior. Okay, superior, medial, inferior, and lateral. Okay, lateral. So in this nuclei, it goes on synapse the vestibule, and then it has connection through the to the 3rd nerve, 4th nerve, and 6th nerve to the medial longitudinal fasciculus. Medial longitudinal fasciculus. So here we will examine the vestibular pathway by 3 important bedside examination. One is Dix-Hallpike maneuver, okay, that will show how to do the Dix-Hallpike maneuver, okay, on the patient. Then the caloric test, how to do, we'll just, and how to interpret, we will just demonstrate that, and pass pointing, how to do pass pointing in vestibular nerve examination. Okay, so now we examine how to look for a Dix-Hallpike maneuver, caloric test, and pass pointing. Okay, now we'll come to a nystagmus in vestibular pathway examination. Nystagmus, as already we have discussed in the last class in 3rd nerve examination, the how to distinguish a peripheral nystagmus from a central nystagmus. So vestibular nystagmus is a peripheral nystagmus. Okay, how to distinguish this from a central nystagmus? So what are the points we discussed? First is the latency. Okay, the peripheral nystagmus, the vestibular nystagmus has a latency. That means when you put a patient in some position to elicit the nystagmus, it takes time to develop it. That is a latent period, unlike in a CNS cause. Then fatigability. If you keep on doing it, it fatigues after some time, unlike the CNS, which is it won't get fatigue. So fatigability. Then habituation. If you do 4-5 times, the intensity of the nystagmus reduces in peripheral, but not in central. Then fixation. If you fix the eyeball or the vestibular apparatus, then there won't be any nystagmus in a peripheral, unlike in a central. The peripheral nystagmus is rotatory in component. Okay, if there is rotatory, it is peripheral in nature. Peripheral nystagmus is rotatory in component. Then the associated oral symptoms, the ear pain, the nausea, vomiting, the autonomic symptoms associated are more severe in peripheral nystagmus. Then the peripheral nystagmus, the nystagmus will be towards the opposite side and will fall towards the same side. Okay, the nystagmus, suppose if the right side vestibular is damaged, it will fall towards the same side and nystagmus will be towards the opposite side, whereas the slow component will be towards the same side. Okay, the fast component will be towards the opposite side in the peripheral nystagmus. Okay, and one more entity in the CP angle tumor, there is a Bruns nystagmus. The Bruns nystagmus is slow and coarse nystagmus towards the same side, fine and rapid nystagmus towards the opposite side. That is a Bruns nystagmus, is a feature of CP angle tumor. So this is about 8th nerve discussion. So total both vestibular and cochlear nerve discussion. So after knowing the anatomy of the 8th nerve, cochlear and vestibular nerve, what are the things you examine here? In the cochlear nerve, you will examine the Rinne's and Weber's test, and the vestibular you will examine 3 tests. One is you will do Dix-Hallpike maneuver, caloric test, and pass pointing. So cochlear nerve, first we will do Rinne's and Weber's test. Before doing on him Rinne's and Weber's test, I want to explain what is Rinne's Weber's, how to interpret it. See, in a normal person, air conduction is better than bone conduction. That means you hit a tuning fork, hit on the masthead process, keep in the masthead process. Once it stops, you keep in the external auditory meatus. He will be able to hear it. That is, AC is better than BC normal. BC becomes more than AC if there is a conduction deafness. That is Rinne's test. Rinne's positive means normal. Weber's test is after hitting the tuning fork, will keep in the middle part of the forehead. It should be heard bilaterally equal. Suppose if it is lateralized to the abnormal ear, means that ear there is a conductive deafness. Suppose if Weber's is lateralized to the normal ear, then that means the abnormal ear is having a sensorineural deafness. Then absolute bone conduction test. Absolute bone conduction test, you need the tuning fork, you will keep on the mastered process of the patient. Once it stops hearing, you will keep on your mastered process, and you should also should not hear. If you keep on hearing, then patient absolute bone conduction is lesser than yours. So that is sensory neural deafness of the patient if it is like that. If both patient and yours is normal, it is normal. If patient's is less, it is sensory neural deafness. If patient's absolute bone conduction is more, then patient has a conductive deafness. Now I will do on all the three tests. Just let us see what the result we get on. Dear student, just watch. सुन रहा है अभी सुन रहा है? Yeah, see, is telling he is hearing when I put in front of the earpiece now, but not on the mastered process. AC is better than BC. This is normal. This remains positive. Okay, right. Suppose if bone conduction is better than air conduction, that is a conductive deafness. Let us do Weber's test. किस तरह ज्यादा सुन रहे हैं, राइट लेफ्ट और इक्वल?
दोनों तरफ ज्यादा.
Yeah, is telling both the sides equally heard. So it is normal Weber's test. Suppose if he says right side it is lateralized, then it is the right sided conductive deafness to the abnormal ear if it is lateralized. Suppose if it lateralized to the normal ear, suppose if it is lateralized to the normal ear, then the abnormal ear is having a sensory neural deafness. Next is absolute bone conduction. सुन रहा है? जब स्टॉप होता है बोलना. बंद हो गया. I am also not hearing. So his absolute bone conduction and my absolute bone conduction is equal. It is normal. Suppose once he stops hearing, if I still continues to hear, his absolute bone conduction is less, then he is having a sensory neural deafness. Suppose if absolute bone conduction is more than mine, then he is having a conductive deafness. If both are equal, it is normal. This is Rinneus-Weber's and absolute bone conduction. Now theory will come. Students, now you have seen the pathway of the vestibular pathway. Let us see how to examine vestibular now under three headings: the Dix-Hallpike maneuver, caloric test and post pointing. So first I will do Dix-Hallpike maneuver, how to do it. Dear students, Dix-Hallpike maneuver, okay, I will be doing now. Turn the head towards one side, for example left side, okay, 45 degree, and then make 45 degree down. Suppose if any problem in the dependent ear, then there will be an nystagmus with a fast component towards that dependent ear. Okay, right. Next same thing, turn the head towards the right side 45 degree, then again make 45 degree downwards. Now the right ear is dependent. If any problem with the right ear, then you will have nystagmus with a fast component towards the right ear. This is a Dix-Hallpike maneuver. Dear students, next test is caloric test. For that you have to make the head then 30 degree elevated. You have to put a water to the ear 7 degree above and 7 degree below. 37 if it is a normal environmental temperature, 30 degree and 44 degree water you will put to the ear, and you will see the nystagmus. You know there is a famous mnemonic, cows. Cold water means opposite, warm water means same side. What is that opposite and same side? It is a nystagmus, not the tonic eye deviation. If you put cold water, the nystagmus, cold water to the right ear, nystagmus will be towards the opposite side, to the left side. If you put a cold water to the left, there will be nystagmus towards the right side. Cold is opposite, warm is same side. Cows. That is nystagmus, not the tonic eye deviation. There are two pathologies in a caloric test. For example, if there is a canal paralysis, then you won't get either you put cold water or hot water, no nystagmus will be seen at all. That is canal paralysis. Next is directional preponderance. That means whichever side you put water, there will be nystagmus towards only one side. That you get in brainstem. In brainstem, there will be a directional preponderance towards the opposite side. In a cortical lesion, there is a directional preponderance towards the same side. This is a caloric test. So the next is pause pointing. Pause pointing, you will do like this. Aankh band karna. Upar lana. Okay. Niche la. Yeah. This is pause pointing. It is normal here. Aankh kholna. Suppose aankh kholna. Suppose if there is a right cerebellar problem, the right hand will drift towards the right side. Suppose if there is a right vestibular problem, both the hands will drift towards the right side. This is how you distinguish a pause pointing of vestibular from a pause pointing of a cerebellar. So dear students, after examination of the vestibular pathway, I want to tell briefly about the condition which produces tinnitus and pulsatile tinnitus. Pulsatile tinnitus is in globus jugular tumor. It is nothing but an audible bruit in a carotid stenosis, AV malformations, venous hum, hypertension, Meniere's disease, toxins, acoustic neuroma. Then the peripheral nystagmus and central nystagmus, again I want to repeat once again. The peripheral nystagmus has a rotatory component due to vestibular etiology. It has a latency. It takes some time to develop the nystagmus, not the central one. Habituation, if you keep on repeatedly doing it, the severity will come down the nystagmus. Fatigability, it fatigues after some time, the peripheral nystagmus. Peripheral nystagmus is unidirectional, only in one direction it will be always, whereas central will keep changing central nystagmus. Peripheral nystagmus has autonomic symptoms like nausea, vomiting, and oral symptoms like oral pain, oral fullness. Peripheral nystagmus is severe, peripheral vertigo is severe, unlike a central one. Whereas the central one has a more imbalance. So if right vestibular part is damaged, you will fall towards the same side. First component of nystagmus will be towards the opposite side. Whereas if right cerebellum is damaged, you will fall towards the same side. First component of nystagmus also will be towards the same side. So this is about 8th nerve examination. So like all other cranial nerves, glossopharyngeal also I just want to tell a little briefly about the anatomy of the glossopharyngeal nerve. So here in the brainstem, in the medulla, you have an inferior salivatory nucleus. See, facial nerve I taught superior salivatory nucleus. It is inferior salivatory nucleus. The superior salivatory nucleus of facial nerve supplies which glands? Submandibular and sublingual glands. The inferior salivatory nucleus supplies which is the only one remaining salivary gland? Parotid gland. That's all, very simple. So inferior salivatory nucleus of fibers will be given. Okay. Then the tympanic nerve, tympanic plexus, then otic ganglia. Then through the auriculotemporal nerve of the 5th nerve, it supplies to the parotid gland. Okay. The glossopharyngeal nerve, it supplies the parotid gland. Now, how do you examine the 9th and 10th nerve? Okay, 9th and 10th are usually examined together only. Okay, the reflex which you examine for the 9th and 10th nerve is, that is a gag reflex. So there is a palatal and pharyngeal reflex in the gag reflex. For the elicit palatal reflex, you will touch the soft palate or the uvula. For the pharyngeal reflex to elicit, you will touch the anterior facial wall or the posterior wall of the pharynx or posterior 1/3 of the tongue. Of these two, of the palatal reflex and the pharyngeal reflex is the brisk one and which is more reliable. So what are the three components once you do the gag reflex? What are the three things which you will observe, which will happen? Okay, one is the closure of the nasopharynx, the closure of the glottis, and the constriction of the pharynx. These are the three things which will occur. Now, for example, if the right side 10th nerve, the afferent for the gag reflex is the 9th nerve, efferent is the 9th and 10th nerve. Okay. Suppose if there is a right side 10th nerve is damaged, what will happen to the uvula? Which side it will deviate? So, to make it simple, you have to always remember one thing, 10 plus 7 is equal to 12 plus 5. You remember like that. That means the 7th nerve and the 10th nerve behave in the same way and the 12th nerve and the 5th nerve behaves in the same way. That means 10 plus 7. It behaves like a facial nerve. That means if there is a problem with the ipsilateral side, it will deviate towards the normal side. So if there is a right side 10th nerve is damaged, the uvula will deviate towards the left side. The left side is a normal one, like facial. Whereas the 12th nerve and the 5th nerve behaves in a same way. We discussed last class the trigeminal nerve examination. Suppose the medial and lateral pterygoid on the one side, if it is damaged, Okay, the jaw will deviate towards the affected side only. Okay, towards the affected side only. So you get exaggerated gag reflex in pseudobulbar palsy. Exaggerated gag reflex in pseudobulbar palsy. The vagus nerve supplies all the muscles of the pharynx and larynx except stylopharyngeus, which is supplied by ninth nerve, and tensor valley pallati, which is supplied by fifth nerve. Okay. Suppose if there is a one side 10th nerve is affected, the arch, the pharyngeal, the uvula, the arch on the both the sides of the uvula, that side which is affected, that arch will be lower down because due to the weakness of the levator valley pallati. Because of the weakness of the levator valley pallati. Then two important things in glossopharyngeal nerve is one is glossopharyngeal neuralgia, where they have the pain on swallowing, and one is carotid hypersensitivity, where when they wear tie or a tight neck shirts, the carotid sinus will get stimulated and patient will have syncope, carotid sinus hypersensitivity. These two are important entities in glossopharyngeal nerve you should know. You know the anatomy of the ninth nerve. Okay, so one important reflex which you examine in for the ninth and 10th nerve is the gag reflex. The gag reflex you can do either a palatal or pharyngeal reflex. For a palatal reflex, you can touch the soft palate or the uvula. For a pharyngeal reflex, you will touch the anterior facial pillar, posterior 1/3 of the tongue or pharynx. The pharyngeal reflex is the one which is a brisk and more reliable one. Suppose if ipsilateral 10th nerve is damaged, the uvula will move towards the normal side. That is the opposite side, which is the normal side. It behaves like a 7th nerve. You remember rule of 17. 10 plus 7 is equal to 12 plus 5. 10th nerve and the 7th nerve behave in the same way. 12th nerve and the 5th nerve behave in the same way. That means if 10th and 7th, if one side is paralyzed, the uvula or the face will deviate towards the normal side. Whereas in the 5th and 12th, if one side is paralyzed, it will deviate towards paralyzed side only. So gag reflex, let us see how to examine the gag reflex. It has three components. When you touch either of these things which I told, there is a closure of the nasopharynx, closure of the glottis, constriction of the pharynx. Nasopharynx will get closed, constriction of the pharynx, glottis will get closed. The vagus nerve supplies all the muscles of the pharynx except stylopharyngeus, which is supplied by ninth nerve, tensor valley pallati, which is supplied by fifth nerve. So if ipsilateral 10th nerve is damaged, the arch on that side will become low because of levator valley pallati will be a hypotonia, it is weak. The gag reflex afferent is 9th, efferent is 10th nerve. Now let us see how to examine the gag reflex. Dear students, now I will show how to look for the gag reflex. Now I will touch the posterior pharyngeal wall or the posterior 1/3 of the tongue. Okay, let us see what happens to the uvula. मुंह खोलो, जीभ बाहर दिखाओ. ठीक है. I touch the tongue, you can see the uvula moving there. Okay, dear students, I will do the gag reflex now. He will open the mouth, I will touch his uvula or the posterior 1/3 of the tongue or the posterior pharyngeal wall. करो, जीभ बाहर डालो. ठीक है. Yes. See, it moved up. If I touch, the uvula moved up. He has a sluggish. In fact, 20% of the person's gag reflex can be absent. I think he is the one where there is no response of gag reflex. The De Jong is 20% of the person's gag reflex can be absent. Here, even if I touch the posterior 1/3 or the uvula or the anterior facial pillar, there is no response. Okay, dear students, I want to tell about palatal myoclonus in 9th and 10th nerve examination. Here it is due to triangle of Gillian and Mollerite, due to the problem in the connection between the three nuclei, dentate nucleus, olivary nucleus and red nucleus. That is palatal myoclonus. Now let us go to the examination of the 9th and 10th over the 11th cranial nerve, spinal accessory nerve. So cranial accessory nerve supplies the muscles of pharynx along with the 9th and 10th nerve with the nucleus ambiguous. Only the spinal part we can access by sternocleidomastoid and trapezius. So let us see how to examine the trapezius and sternocleidomastoid. Okay? ये इस तरह करना मैं जब बोलता हूँ, ठीक है? करिए? Yes, करिए? So he is studying the shoulder. This is the trapezius muscle examination. Now sternocleidomastoid. Sternocleidomastoid mastoid helps in looking the face toward the opposite side whenever ipsilateral sternocleidomastoid mastoid is contracted. आपका बाएं हाथ की तरफ टर्न करिए. Yeah, you can make out the prominent sternocleidomastoid on the right side. Okay. Now, Gopal, आपको दायां की तरफ टर्न कीजिए. Apply the resistance counterlateral. You can make out the prominent sternocleidomastoid here. Suppose if you want to look both the sternocleidomastoid, if you want to test, ask him to flex it against the resistance. इस तरह करना मैं जब बोलता हूँ, करिए. Yeah, you can do it like this. Sternocleidomastoid muscle is absent in bilateral absence in myotonic dystrophy. Okay, and sternocleidomastoid muscle overaction will produce torticollis. Due to the overaction, the head will turn toward the other side. This is examination of the 11th cranial nerve. The last cranial nerve is the 12th cranial nerve. How to examine the 12th cranial nerve, I will tell. The muscle supplied by 12th cranial nerve are styloglossus, hyoglossus, palatoglossus, genioglossus. You can test the patient by putting the tongue inside and outside, side by side, up and down. जीभ है ना, पहले बाहर अंदर, उसके बाद ऊपर नीचे, उसके बाद साइड टू साइड, मुंह ओपन कर करना. बाहर अंदर अंदर, साइड टू साइड, राइट लेफ्ट, ऊपर नीचे नीचे. ओके. The other way to examine the tongue is ask the patient to put a tongue against the cheek. You try to displace it. However strong you are, you can't displace the tongue. That's what given in books. Let us see whether I can able to displace his tongue against his cheek. ये जीभ है ना, इस तरह होल्ड करना. ओके. See, I am not able to displace it. He is holding it tightly so much. ठीक है बस. Okay. 12th nerve, suppose if ipsilateral 12th nerve is damaged, the tongue will deviate towards the damaged side only. 12 plus 5, 17. Okay. Trigeminal nerve and the 12th nerve behave in the same way. Whereas the gag, the 10th nerve and the 7th nerve behaves in the same way. They will deviate towards the normal side. This is the examination of the 12th cranial nerve. Dear students, after examining all these cranial nerves, I want to tell there are some conditions which produces multiple cranial nerves, and there are some diseases which encountered with the multiple cranial nerve palsies. Which are the diseases? Multiple cranial nerve palsies. Diabetes can affect because of vasculitis. Guillain-Barré syndrome can produce a multiple cranial nerve palsy. Demyelinating disease, multiple sclerosis can produce a multiple cranial nerve palsy. Meningitis, tubercular meningitis infection can produce a multiple cranial nerve palsy. Myasthenia gravis, motor cranial nerve palsy it can produce. Craniovertebral junction anomaly, lower cranial nerves it can damage. Motor neuron disease, multiple cranial nerves will be affected. Polycranialis neuritis, multiple cranial nerves will be affected. Tumors can affect the multiple cranial nerves. CP-angle tumor, for example, 8th nerve, 5th nerve, 7th nerve. Nasopharyngeal carcinoma, it can produce multiple cranial nerve paralysis. Vasculitis, vaginous granulomatosis, it can produce multiple cranial nerve paralysis. Any vasculitis due to any etiologies. So, demyelinating, infective, autoimmune, tumor, multiple sclerosis, Guillain-Barré, motor neuron disease, diabetes. So, these are the diseases which can produce multiple cranial nerve paralysis. There are some syndromes, for example, jugular foramen syndrome, 9th, 10th and 11th will be affected. Gradidigo syndrome, which I discussed, petrositis due to the infection, due to the inflammation, malignancy or trauma. 6th nerve paralysis, along with the ophthalmic distribution, there will be a sensory loss, Gradidigo syndrome. Superior orbital fissure syndrome, 3rd, 4th, 6th, along with the ophthalmic division of the 5th nerve. Cavernous sinus syndrome, where there will be a 6th nerve involvement along with the 3rd, 4th, ophthalmic and maxillary division of the 5th nerve. So, cavernous, superior orbital fissure syndrome, jugular foramen syndrome, CP-angle tumor, 8th nerve, 7th nerve, 5th nerve, 9th and 10th nerve can be affected. So, after examining all these cranial nerves, you should be able to, the one thing important, dear students, anatomy is very important to localize and diseases. Diseases are, it can be infective, demyelinating, tumors, trauma. Etiology will be easy, but anatomy to localize, you should know thorough anatomy. I hope you have understood and able to interpret henceforth the cranial nerve pathways, clinical features, etiologies, and differential diagnosis. So next is the 12th nerve examination, that is the hypoglossal nerve examination. Okay, so let us go to see how to examine for the hypoglossal nerve examination, that is the 12th nerve. Okay, so we examine the hypoglossal nerve examination. Okay, the muscles of the tongue are hyoglossus, styloglossus, palatoglossus, okay, genioglossus. For the fasciculation, you will examine the patient with the tongue inside the mouth. For tremors, you will examine the patient by putting the tongue outside. You can ask the patient to move the tongue inside, outside, upward and downward, medial and lateral, and examine the patient. Okay. Then before 12th nerve, the spinal accessory you have to examine. Okay, spinal accessory nerve examination. Spinal accessory nerve examination is done by examining the trapezius and also sternocleidomastoid. Okay, sternocleidomastoid and trapezius, how to examine, we'll just go beside the patient, I'll show now. Okay, now you know how to examine the trapezius muscle and sternocleidomastoid. Here you remember you are examining the spinal part of the accessory nerve, not the cranial part. The cranial part will be mixed with the 9th and 10th nerve together. Okay, it supplies the muscles of the pharynx along with the 9th and 10th. Okay, so this is about the examination of the cranial nerves. Okay, now after examining all these cranial nerves for the last 3 classes, okay, you should know something to summarize it and how to analyze when the brainstem, the cranial nerves are involved. Okay, now first let me say which are the pure motor cranial nerves of all these 12 cranial nerves. The pure motor cranial nerves are 3rd nerve, 4th nerve, 6th nerve, 11th nerve, 12th nerve are the pure motor cranial nerves. Which are the pure sensory cranial nerves? 1st nerve, 2nd nerve, 8th nerve, pure sensory. Which are the mixed ones? The 9th one, 7th one, 10th one, 5th one, 7th one, 10th one, 9th one, they are the mixed cranial nerves. Okay, right. Now you get some of the in the brainstem involvement, some of the syndromes, okay, because of this cranial nerve affection. Okay, what are the midbrain syndromes you get? Already we discussed while examining the while discussing the oculomotor nerve. So ipsilateral oculomotor nerve with a contralateral hemiplegia is Weber syndrome. Ipsilateral oculomotor nerve with contralateral tremor is Claude syndrome. The combination of this ipsilateral third nerve palsy with contralateral tremor and hemiplegia is Benedict syndrome. There is North-Angel syndrome, ipsilateral third nerve palsy, ipsilateral cerebellar ataxia with a vertical gaze palsy, that is North-Angel syndrome. Now coming to the Pontine syndromes. So midbrain syndromes are those. Pontine syndromes are ipsilateral 7th nerve palsy with contralateral hemiplegia, that is Millard-Gubler syndrome. Fovili syndrome, ipsilateral 7th nerve palsy, ipsilateral lateral gaze palsy with contralateral hemiplegia. Even 6th also will be involved along with 7th nerve. Ipsilateral 6th nerve palsy with contralateral hemiplegia, Raymond syndrome. Okay, now we discuss midbrain and Pons syndrome. Then what are the medullary syndromes? Medullary syndromes, lateral and medial medullary syndrome. Very easy to remember if you know the anatomy. Okay, so here first I'll put a lateral and medial medullary syndrome diagrams to understand. See, this is the lateral part of medulla. What are the structures present here in the lateral part of the medulla? Just see here. There is a vestibular nucleus. Okay, so what they will have? They will have vertigo because vestibular nucleus is situated. See, medial vestibular nucleus, inferior vestibular nucleus. So they will have vertigo. You have a nucleus and root of the 5th nerve. The descending nucleus of the 5th nerve will descend down till C2, which carries a pain and temperature. So they will have ipsilateral loss of pain and temperature of the phase. Okay. Then you have a spinocerebellar tract here. See, ventral spinocerebellar tract. So patient will have ataxia, cerebellar ataxia will be there. And here you see lateral spinothalamic tract, which is from the opposite side of the body, carrying the fibers of the pain and temperature. So patient will have loss of pain and temperature on the opposite side of the body. So ipsilateral loss of pain and temperature of the face, contralateral pain and temperature of the opposite side of the body. Vertigo due to vestibular nucleus. Spinocerebellar tract will be affected, so ataxia will be there ipsilateral. Most of the signs are ipsilateral, only pain and temperature affection of the body is the contralateral. Then nucleus ambiguous. Nucleus ambiguous contains the fibers which carries the fibers to the muscles of the pharynx from the 9th, 10th cranial nerves and even 11th. So they'll have dysphagia, okay, nasal regurgitation due to the nucleus ambiguous involvement. Dysphagia, nasal regurgitation, hoarseness of voice, and even sympathetic chain runs here in the lateral part of the medulla. So ipsilateral Horner syndrome. So if you know the anatomy, very simple. Lateral medullary syndrome, ipsilateral Horner syndrome, contralateral pain and temperature, ipsilateral face pain and temperature, vertigo, dysphagia, dysarthria, hoarseness of voice, nasal regurgitation, ipsilateral Horner syndrome. So what is medial medullary syndrome? See the diagram here. Which is the nucleus present medially? Nucleus of the 12th nerve. And which are the tracts? See here, pyramidal tract is there and medial lemniscus is there. And these two will be, pyramidal tract still low down, crosses and supplies the opposite side of the body. It comes here, crosses and supplies the opposite side of the body, this side. Okay. The medial lemniscus would have crossed here and come here. In the medulla it would have crossed here and come here. So if there is a problem here, there will be ipsilateral 12th nerve palsy in medial medullary syndrome, ipsilateral 12th nerve palsy, contralateral general touch and fine touch vibration will be affected, and contralateral motor weakness. Okay. So in a medial medullary syndrome, ipsilateral 12th nerve palsy, contralateral fine touch vibrations, proprioception will be affected along with the contralateral motor weakness. These are medullary syndromes. In the brainstem, always it is a crossed syndrome. So because corticospinal tract will decussate in the lower part of the medulla, whether it is a Miller-Gubler, Raymond's, Weber's, it is all crossed. Ipsilateral cranial nerve will be affected, contralateral there will be a hemiplegia. Okay? Right. So these are the medullary syndromes. Now what happens if there is a foramen magnum lesion? In a foramen magnum lesion, there will be a cruciate paralysis, which I discussed in the first class only. Why there will be cruciate paralysis in the foramen magnum lesion? Because the leg fibers will decussate at the lower level compared to the arm fibers. With the diagram I had shown you why there will be a cruciate paralysis. And there will be a small muscle wastings in the foramen magnum lesion due to venous congestion in the anterior horn cells of the spinal cord. There will be a C2 sensory loss will be there. There will be layer-mediated sign will be there, and shawl-like distribution of the loss of sensation over the body, and there will be downbeat nystagmus in foramen magnum lesions. So what are the things you get in foramen magnum lesions? Small muscle wasting of the hands due to venous congestion will be there. Cruciate paralysis or hemiplegia alternans or crossed hemiplegia. C2 sensory loss, layer-mediated sign, shawl-like loss of sensation over the back of the body, and downbeat nystagmus. Now, if all these cranial nerves are affected in the brain stem, it will produce a progressive bulbar palsy. There are some diseases which produces progressive bulbar palsy. For example, motor neuron disease, myasthenia gravis, some of the myopathies, Guillain-Barré syndrome, diphtheria, botulism. That means they involve the lower cranial nerves in the brainstem. Okay. Even syringobulbia can produce progressive bulbar palsy. It extends to the brainstem. So I repeat, which are the diseases which produces progressive bulbar palsy? That is the 11 cranial nerve affection of the brainstem. Motor neuron disease, it will produce mixed both upper and lower motor neuron MND, both UMN variety and LMN variety. That is pseudobulbar palsy and bulbar palsy. Both it can produce. Myasthenia gravis, diphtheria, botulism, Guillain-Barré syndrome, syringobulbia, all produce progressive bulbar palsy. So, after discussing the cranial nerves, this is the in a nutshell how to approach a brainstem problems. Okay, so this is about the discussion of the cranial nerves, what we discussed in the last 3 classes. Okay, acknowledgement for all these diagrams is from De Jong Neurology, 7th edition, published by Wolters and Kluwer, Private India Limited.